I'm Ellen Mendelsohn, Professor of Radiology at Northwestern in Chicago. Today I'll be talking about automated ultrasound for breast cancer screening and the use of automated ultrasound for whole breast surveys. In today's presentation, I'd like to talk about the need for supplemental breast cancer screening, the results of the Akron 6666 trial, what methods we might use for screening, either handheld ultrasound, automated ultrasound, and why one may be preferable to the other. I'll provide for you a bit of historical perspective and show you how an automated scanner can function in the very busy breast center workflow. We'll also talk a little bit about a multicenter trial of lesion detection with handheld versus automated scanning that will precede widespread screening. Well, what is screening? Screening is the detection of unsuspected disease, and the disease should be of high prevalence, as breast cancer is. The screening method should be affordable, repeatable, accessible, of low risk, and provide effective treatment. And effective treatment should be provided. What is accepted for breast cancer screening at the current time? It's mammography and physical examination, and for the highest risk group, contrast-enhanced breast MRI. What about a role for ultrasound? Breast cancer is the #1 cancer for women, with 180,000 to over 200,000 new cases per year in the U.S. For 2010, the expected number of cases is 207,000 invasive cases and about 53,000 in situ cases. Breast cancer accounts for about 40,000 deaths per year, with mortality rates reducing by about 2.3% per year since 1990, with earlier detection and better treatment as explanations for the reduction. What are the breast cancer screening recommendations in the United States? Mammography, annually starting at age 40 for most women, and their mortality reduction of over 15% from randomized controlled trials provides the evidence. There has been a publication of the U.S. Preventive Services Task Force, a government advisory panel based on statistical models, to start mammography not at 40 in the U.S., but at age 50, and to perform it for women of average risk, not high risk, but of average risk, every other year. Why this new recommendation? Could it have an economic basis in this time of healthcare cost crisis? We have found many younger cancer patients whose ages range between 35 and 49, and should we start screening at age 50, we would expect many more late-stage cancer diagnoses. MRI is part of the recommendations for screening, and there it's for highest risk women annually in addition to mammography, particularly where the lifetime risk is greater than 20%. Ultrasound for dense breasts and elevated breast cancer risk, but up to now there has been no recommendation from the American Cancer Society or other bodies for screening with ultrasound. We expect a change this year or next year in the American College of Radiology practice guideline for the performance of breast ultrasound. In 2007, the most recent version, ultrasound is listed as an area of research for screening. In 2011, we would like to see a change in that we recognize data supporting ultrasound screening in addition to mammography, not instead of, for women with dense breasts at high risk of breast cancer. Well, what are the limitations of mammography? These are something we must recognize. They're inherent. Mammography does a fantastic job in breast cancer screening, but it has limitations, as every modality does. Contrast limitations are what provides the problems in mammography. Can we see masses in dense breast tissue? I'll show you an example of what is really white on white, and it makes a mass hard to see in the dense white fibroglandular tissue. And this type of tissue, a normal type of tissue component in breast, can reduce sensitivity of mammography by up to 50%. Any woman, young or old, can have dense breast tissue. The women who are young, younger than 40, younger than 30, have denser breasts, and very young women have higher radiosensitivity. Just for your orientation, I've labeled on these medial lateral oblique views back to back of the left and right breast, the muscle, this triangular area that you see in the upper part of the image. The fibroglandular tissue is dense and white. The skin you can trace, here's the nipple, and the dark areas of tissue are fat in the breast. Now, on the left side, because this is a mirror image, the left breast has a pseudocancer that I've placed against the fat. It's an asterisk, and there's a second one here. Can you see it? I could ask you if it's in the other breast or somewhere in the same. It happens to be in the same breast, and it's in the upper portion, and with contrast, now where I've shown it in black, it's easily perceived. So white on white is difficult, and that is the contrast limitation you'll find in mammography. Well, who is at risk for breast cancer? Women whose age is increasing, women with a family history of breast cancer and first-degree relatives, and those are mothers, sisters, and daughters, and fathers, especially when the first-degree relative is premenopausal and has bilateral breast cancer. When there has been a previous biopsy with a histology of lobular carcinoma in situ, atypical lobular hyperplasia, atypical ductal hyperplasia, and the last I've listed in this group, ductal carcinoma in situ, is not really a high-risk marker. We count it as cancer. Personal history of breast cancer and radiation for Hodgkin's lymphoma, where one might expect the risk of cancer, breast cancer, to increase after as soon as 8 or 9 years have passed. Hereditary breast cancer accounts for about 10% or up to 10% of the breast cancers we find. And there, if you think of 200,000 as the total in the U.S. per year, we might say between 10 and 20,000 cancers are of the hereditary type. BRCA1 and 2 are abnormal breast cancer genes, and the women who have those have very high risk. For BRCA1, it's 87% lifetime risk, and 50% of those women have their disease found by age 50. A very important study completed now with the first-year results having been published in 2008 is the American College of Radiology Imaging Network, the Akron Study 6666, which is was performed in conjunction with the National Cancer Institute. And what happened in this study was that handheld ultrasound, physician performed by experienced ultrasonologists in 2,800 women who had dense breasts and had high risk, were interpreted independently from mammography, also performed for these women. Final assessment categories were assigned 1 through 5 based on BIRADS, the American College of Radiology's breast imaging, reporting, and data analysis systems, a feature analytic approach for ultrasound, for mammography, and for MRI. The goals of the study were to find the independent contribution of ultrasound and to do a cost analysis. The cost analysis is still being worked on and has not yet been published. The first-year results of Akron 6666 were published in JAMA in 2008, and there the diagnostic accuracy of mammography plus ultrasound was found to be 91%, with mammography alone 78%. The diagnostic yield of mammography alone was 7.6 per 1,000 women screened, which is how you calculate it. And when ultrasound was added, it rose to 11.8 per 1,000 women screened. Of these cancers that were found with ultrasound, 12 were found only with ultrasound, not with mammography. 11 of them were invasive, and of the women whose axillary status we knew, 8 of 9 had negative lymph nodes. The supplemental cancer yield of ultrasound then, we found in a range of 1.1, which is low, to 7.2 per 1,000 women screened, with an average of 4.2 per 1,000 women screened. There were a large percentage of false positives, and we were concerned about that. Only 8.9% of the biopsies showed cancer, but we recognized that the first year was a prevalence screen for ultrasound. In other words, there had been no previous ultrasound studies to compare with, as we had for the mammograms. Many of the women had years of mammographic studies that we could compare with. With the comparison studies available, we expect that years 2 and 3 will be better in terms of positive predictive value. Nevertheless, lack of ultrasound specificity has been something of concern for decades. As we look at ultrasound as a modality, we always think of it as operator dependent, and some of the past limitations of ultrasound were its inadequate spatial resolution, its small field of view, 5 centimeters squared, really maximally, these overlying speckle, coarse, noisy image, poor, inconsistent scanning technique, and for breast, inexperience with ultrasound anatomy and pathology. Its diagnostic use was limited to cyst versus solid, without permission really to look at solid masses and try to distinguish among them. And there was no standard for lesion analysis and reporting before BIRADS was published in 2003. With automated scanning, rather than a small field of view, the entire breast anatomy is depicted, no matter what the method of automation is, whether it's supine, whether it's prone, water bath, or helical in terms of its acquisition. You see the entire breast. And these acquisitions are volumetric, so they enable reconstructions of other views, just as we can with CT and with MR. So that if, as we concentrate today on the supine automated scanner, the acquisition is a linear acquisition in horizontal plane, and it's a very wide, up to 15 centimeter acquisition. And this acquisition will allow a reconstructed coronal plane. The entire breast in coronal plane is new for ultrasound, and we're learning its applications. There is also a vertical reconstruction. So we have 3 planes, as we do, say with stereotactically guided biopsies, an X plane, which is horizontal, a Y plane, which is vertical, and a Z plane, which is anterior posterior. It's the depth plane. There is no radiation, no ionizing radiation from ultrasound. Showing you how we can depict anatomy more completely, this is anatomy deep in the breast near the chest wall, and at the top of the image you see ribs. Down deep in the image is the thorax. Above you see ribs in periodic array. Above the ribs you see muscle, and the detail is good enough for you to visualize the muscle bundles that comprise the pectoral muscle. And above that, some fat. There's very little breast tissue in this one image, as you can see. And then at the top is the skin. The little yellow square is showing you where on the breast anteriorly is the nipple. But go to the coronal reconstruction, and what you see is in detail is the anatomy of the sternum with the costochondral junctions and ribs emanating from it. And all the portions of the sternum are visible. And here in this vertical reconstruction, the periodicity of the ribs is something that you can appreciate. There is a diagrammatic representation of your location of scanning. You see that on the bottom of the image here. If you look at the anatomy of the breast in full coronal view, again a reconstruction at the skin, you'll see pores. And I wanted to show you this image because this patient has had a breast reduction, and the scar, that vertical scar from the areolar region down to the inframammary fold, is visible. The symmetry is easily seen, and the architecture is readily appreciable when it's normal and when it's disturbed. Here in another patient is the anatomy at the skin. The nipple is recognizable. You can see a portion of the areola, and what you also see are prominent pores in her skin. This patient has inflammatory breast cancer, late stage breast cancer, and this was at the skin of the affected breast, and it looks very different from the two cases I showed you previously. The skin is thick, it has edema within it. The MR study is shown for correlation here. The very thick skin, it's a centimeter thick, where normally it should be 2 millimeters in thickness. And these lines that you see going through the coronal view represent edema, and the swelling of the skin and tissues is also appreciable here around the nipple and in the periphery of the breast. This slice is reconstructed a little bit more deeply in the breast at the level of one of the many masses that were found within her breast. It was grade 3 invasive ductal carcinoma that had affected the lymphatics. Another case, and I'll show you several cases. It's probably the easiest way to appreciate what automated scanning can do for you. Here's a 47-year-old with no family history of breast cancer and a mass that was tender and palpable behind her right nipple, and it was somewhere hidden in this white fibroglandular tissue. Targeted ultrasound, handheld, initially showed right at the site of the palpable mass a 2-centimeter simple cyst at 12 o'clock, and here it is. No other abnormalities. And we then went to an automated scan. Many women have multiple masses, both cystic and solid, and we wanted to see if perhaps this patient had other areas of involvement. The dot is on her nipple, and what you see adjacent to it, and this is deeper than the skin level, is another area. It's hypoechoic. You can see glandular tissue looking white, and the margins of this area are somewhat irregular. We went then, this is the acquisition scan, and you can see here with a portion of the skin not visualized on this scan that there is a cystic and a solid component of this tubular structure, which was a duct that contained, and here in the vertical reconstruction, an area irregular, and within the glandular tissue of this breast, a solid component, and anterior to it, a cystic component. So we have here evidence of an abnormality that requires further evaluation. We did a biopsy, and this was an intraductal papilloma, unsuspected. This is muscle, and here the shadowing that you see is artifactual, where the breast tissue and the fat lobules, which are hypoechoic, intersect. One thing that the automated scan enables you to do, because of its long or its wide acquisition, is to measure the distance between two lesions. This makes it easier when you are looking at cancers to assess multifocality or possibly multicentricity. Here we have a distance that isn't very far. You have centimeter markers, and this was about 1.5 centimeters between the cyst and the papilloma. And here, on just for correlation, is the handheld depiction of the same lesion, here with wide field of view, here with the small field of view. And I think the detectability and the diagnostic potential of the automated scanner can be seen. Well, as we look at breast ultrasound, concomitant with development of automated scans, we've seen developments in handheld scanning. And how has breast handheld scanning changed in recent years? Many manufacturers are offering elasticity assessment, tissue stiffness assessment, and there are various methods that they employ to enable the stiffness assessment to be done. Matrix and volume acquisitions or enable multiplanar reconstructions, as we've seen with automated scans, but also available with handheld small fields of view transducers at high resolution. And all of these volume acquisitions will enable a CAD, a computer-aided detection or diagnosis based on BI-RADS to be developed, and there has been development in this area. 3D and 4D now is available at high resolution. There are calcification algorithms that some systems manufacturers are developing. But again, we are working in small fields of view, and I think we still have need for automation for the wider fields of view. Looking at ultrasound and looking at any modality, we have to look at specificity and sensitivity. Specificity is defined as the true negatives in the numerator over a denominator comprising false positives plus true negatives. And what it really means is the probability of normal findings when no cancer exists. Sensitivity, true positives over true positives plus false negatives, and there we're talking about false negatives that are largely unknown without a link to a tumor registry. They only come to light later, sometimes in sad situations. So just some examples of the specificity problem. I'm showing you here 5 sonograms and 1 little mammogram, and of these, Can you determine which one of these 5 is benign? I'll tell you, but it would be very difficult for you to guess. It's this. This happens to be a duct with a very thick inflammatory wall, and this was benign. This is the open lumen of the duct in cross-section. This is a grade 3 invasive ductal cancer. This is a grade 3 invasive ductal cancer, looking quite different. The first one I showed you, if the technique were less than optimal, might resemble a cyst and an error could be made. And here, a very subtle change in the architecture of the glandular tissue, which is light gray, and the fat above it, which is darker gray. A small invasive lobular carcinoma, and here also looking quite circumscribed, but really isn't, is a mass behind the nipple. That was also a papillary carcinoma. So again, just to show you how difficult it can be. Elastography can show you tissue stiffness, a hypothesis being that cancers are stiff and benign things are soft, which is not always the case. Some cancers are soft, many mucinous cancers are soft, and there are benign, very firm tissues, as in stromal fibrosis. But in general, this hypothesis is helpful. And here a cancer in its B-mode image on the left, and on the right a color overlay that shows you the stiffest, reddest portions of the lesion. Usually the scale is seen at the right side of the image, and here you can see hard and soft. In the United States, the FDA has not yet approved a quantitative measure of stiffness, no matter what the method of elastography. We are awaiting the FDA's change of heart. I think that will be helpful. The specificity problem, here you need clinical correlation. Both of these images are from the same patient, and here is architectural distortion. You can see that the glandular tissue, this is muscle below and fat above, but the glandular tissue is distorted, and there are all of these little hypoechoic areas in it. 2 months later, this is what this patient's area of concern looked like. Her skin was then thickened, there was edema around it, and this is a postpartum mastitis that has progressed to abscess formation 2 months later. So you can't be sure. You need the clinical history, you need correlation of all of the imaging studies if others have been done. Can we screen with handheld instrumentation? This is a question that we really have to ask ourselves, and we look to the Akron Study for some guidance. In physician-performed handheld bilateral ultrasound, it took 19 minutes on average for a study to be completed. And 19 minutes of physician time, is that possible in the United States in 2010, in 2011, in 2012, as we do more and more of these studies? It's uncompensated, and there's really no way that this can be allowed. But can a sonographer or a technologist perform, and the breast imager, a physician, interpret? A sonographer or a technologist is really not licensed to render an interpretation, and we don't have data. It's an unanswered question. If this kind of screening could be done, it's possible that large-scale instruction and experience might give a positive answer there, but we haven't gotten to that point yet. Survey scanning with handheld small field of view is really a mosaic made of small, many pieces that are knitted together by the brain. And as one scans, one is interpreting at the same time. You just move over the breast and knit together these little mosaics. So with handheld ultrasound, the performer and the interpreter in real time are the same person. With limited physician experience and time and decreased availability of this study, I think the demand for handheld ultrasound performed by a physician cannot be met. So there's a need for something else, and the something else is probably automation. And when we look to automation, what might we want? Do we want multimodality fusion? When automation was first considered, many of the mammography interpreters had little experience with ultrasound, and they sought ultrasound fusion with mammography. MR, as the learning curve now increases, and many mammography and ultrasound breast imagers are learning MRI, there's some thought about fusion with ultrasound and MRI, particularly for biopsy purposes. Now, what about patient positioning? Supine, prone, upright? One principle of ultrasound is the minimization of tissue thickness so that you have higher resolution and the penetration depth is lessened. Can we do prone automation? We can do it, and we can see some of the results there that are fairly good. But supine, in terms of the theory and physics of ultrasound, would be the way to go. 3D multiplanar reconstruction is important, and volumetric acquisitions can also support CAD systems for detection. The wide fields of view, 14 to 15 centimeters in 2D, in the supine automated scanners really counters the small field of view compromise of handheld. What might be applications of automated systems? We can look at and for multiple masses to be examined at time 1 and later followed up, and you will be able to identify mass 1 as mass 1 and mass 2 as mass 2 and know which ones are which ones, which has been a criticism of follow-up of lesions, mass lesions, with handheld ultrasound. So we can use it also for follow-up of benign and probably benign lesions. BI-RADS characterization and structured reporting can be entered into these systems, and in newly diagnosed cancers or patients suspected of having cancer, the search for additional abnormalities, in other words, extent of disease evaluations, can be performed with automated systems, just as they can with MRI, which at the current time is the most sensitive modality for these studies, and also then for screening. Historically, automated ultrasound is not new. Ultrasound itself dates back to 1951 with A-mode ultrasound, and the potential of X-ray mammography began to be realized in the 1950s with the work of Gershon Cohn, Egan, John Wolfe, and many others, and at that time interest in ultrasound diminished. There was fear of ionizing radiation, which led to a renewal of interest in ultrasound in the 1960s and 70s when there was development of ultrasound systems, whole breast systems, in Japan, Australia, and Germany. And then in the 1980s, in the U.S., we had whole breast systems developed by Technicare and Labsonics, the latter a company located in Indianapolis that no longer exists. The design and construction of a breast scanner began in Australia in 1963, and if you look at some of these scans, or the table and the water bath there that provided some compression on the breast, just as we see now, it's a little bit more primitive looking, but ultimately, and ours is more streamlined, but the resemblance, I think, is there. At that time, you also had compound scanning, but it was from more than one transducer, and here we can see the intersection of beams, which provides you with a spatial compounding, just as we have in our current high-resolution transducers. So here's an example of the Labsonics. This is more recent than 1963. The transducer would come down and traverse this plastic shell in which there was water, and then making contact with the breast, a polyethylene bag. Here's the breast and the type of image that was generated at that time. This is a fibroadenoma, but each of the fat lobules is definable, and you can see down to the chest wall, and the skin is nicely depicted in both of its layers. So looking into the future, we have an automated scanner, supine, a linear high-resolution scanner with wide field of view, and we started working with this scanner a year or so ago, and it acquires in 3 planes, orthogonal, coronal, and it has multiplanar reconstructions, as we've discussed. The image is generated through a mechanical traversal of the transducer from inferior to superior, the contact with the breast made by a mesh screen and a thick lotion placed on the patient's breast to reduce any possibility of air. There's mild compression to immobilize the breast, and the transducer frequency that we are using currently is a wide aperture broad bandwidth transducer, 14 of frequency range 14 down to 5. There's a handheld system upon which the automated system is integrated, and the views per breast for complete coverage are 2 to 3, currently 3, an AP view, a lateral view, and a medial view. With all of the supine scanners, there is limited visualization of axillary tissue, and the axilla, should you want to scan it, is ideally suited to handheld interrogation. The non-physician acquisition time for 2 breasts in our study done last year was 10 minutes, 60 seconds per view, and electronic image review was then performed. And there are many user-defined hanging protocols, which I'll show you, and how you use these hanging protocols has a large impact on the efficiency of your review and interpretation. The recall rates of screened patients was a workflow and cost concern, and Dr. Tula Destunis in Rochester looked informally at 1,300 patients whom she screened and had a low recall rate of 4%. This was reported but at the RSNA a couple of years ago, but the results were not published. This is an example of this automated system, and there are others. This isn't the only one. There's a second supine system as well that is FDA approved and on the market. But and very similar in its design to this. Here the transducer is housed, and the mesh screen is bordered by this gray zone. It comes down against the patient's breast. You can see it here as it makes contact. Once the positioning is assured, a lock is engaged, and the transducer automatically goes from the lower breast, where it's placed, to the upper breast, and then releases. And then this would be the AP view, and then the other views can be positioned for subsequently, and additional scans obtained. So this is the right anterior posterior view, and we center the nipple with the probe arrow located in the center of the footprint, as you see here. The right lateral view is done with the patient not moving, but the breast moved towards the medial aspect, exposing the lateral portion of the breast to the transducer. So here is how that would be done, and the portion of the breast that would be depicted is shown in blue. Similarly, again, without moving the patient, the breast tissue for the medial view is moved laterally, and the area that you see is on the area of the image is shown in blue. What can you see, and how does pathology show itself in these views? Here is the acquisition view. It's located in the upper outer quadrant of this breast. The nipple in this portion of the coronal image in the left lateral view is for your orientation, and then going to the upper outer quadrant, the lateral aspect, as you can see here, is an area where spicules extend from a hypoechoic mass, possibly calcification seen within it, but on the acquisition view, which correlates with it, and where the crosshairs intersect are the three correlative views: the acquisition view, the coronal reconstruction, and then the vertical reconstruction. What you do see is the mass with the architectural distortion around it. The tissue planes are being destroyed by the advancing cancer, and the skin is thickened above the cancer and being pulled down. This is skin retraction. You can see it also in the view that is vertical, and its extension towards the chest wall will not tell you. It doesn't tell you on ultrasound ever whether or not the chest wall is invaded by tumor. For that, you need enhancement on MRI to be able to be confident in saying that you have chest wall invasion. But the coronal view is remarkable in showing you the architectural distortion face on. And there you can see the rest of the architecture better on an AP view here, but the focus is on this cancer. Do you see this other little hole? This was a cyst. And frequently you will be able to pick out lesions easily in the coronal view. One way to look at these images is in this tomographic depiction, and you can select the slice thickness as you go anteriorly through the posterior aspect of the lesion. Other ways to look, and there are many tools that you can see here in the toolbar which enable you to look any way you would like, and it's important to find a particular way that you use each time to look at cases to shorten the period of interpretation so that you can be efficient in your reporting. This is an example of a single slice hanging protocol where the acquisition view and the vertical view are smaller than the reconstructed coronal view, and this is a right lateral view accentuating the lateral tissue of the right breast. Orient yourself to this scan with the nipple seen in the yellow box and the magnifier over 3 cysts. One is a small simple cyst, another is just a simple cyst, and the third, and you can see on both the acquisition view and the coronal view, a small calcification in the dependent portion of the cyst. So the resolution is quite good here. Looking outside of the magnifier, you can also see additional small cysts and some dilated ducts. The correlation among the 3 images is excellent, and your overall orientation can be shown in this round diagram and in the diagram of the 2 breasts. Depth you can always tell by the scale that you'll see at the side of the acquisition and the vertical image, and there is also a depth measure for the coronal view as well. So 3D orientation is possible. One thing important if one is going to use these scanners for follow-up is the ability to look side by side at last year's or the year before's image compared with the current one, and the workstations enable the comparisons to be shown. Another example of how you might see a cancer on 3 different views and its relationship to the nipple, again in the yellow box. And here on the coronal view, it's easy to pick out this irregular mass. And you can also evaluate the rest of the architecture as well, and perhaps find a second area. Resolution is good on this acquisition with spicules extending from the hypoechoic mass and calcification seen centrally and within the mass itself. In the coronal view, you can see the mass itself. Here the coronal view is quite small, and you get an overview, and the location of the scan is about 1.5 centimeters from the skin. What the vertical view can show you, and you can zoom any of these views also to see them larger if you need to, is the periodicity of some of the artifacts that you would expect from the intersection of curved surfaces, the fat lobules with the glandular tissue beneath it. And here it will help you to exclude the possibility of small masses that cause posterior acoustic shadowing. So these can help you in many instances. Another case showing you 2 cancers. They are both high grade, and one here, a second here, and the distance between them is measurable. Another case, here, 47-year-old with an area that was palpable in the right upper outer quadrant. And this may be another application for automated ultrasound because of its wide field of view and its depiction of larger areas of the breast. So on the mammogram, you have heterogeneously dense or scattered fibroglandular densities with an area of asymmetry in the upper right breast compared with the corresponding area of the upper left breast, which is fattier, And going to the other view of a screening mammogram, or the craniocaudal view, in this case the mammogram wasn't for screening. The patient had a palpable mass, so this was a diagnostic study, and the marker shows where she felt something. And it's this rounded area that is in the same area of the asymmetry on the medial lateral oblique view. And again, you can see in the outer left breast compared with the right that the area is fattier and there's less glandular tissue. So the asymmetry holds in two views, and one would wonder about an underlying mass to explain it. Well, the first thing that we did was to do a handheld sonogram, and it was done initially by the sonographer and then checked by the physician. And in talking with the patient and in palpating that area, it became evident that this area that the patient felt was more apparent when she was in a seated position, so the handheld ultrasound was done in that position. What was found in the handheld ultrasound was a rounded area of echogenic fibroglandular tissue, similar in size and in the location of the palpable area in question. And this area of glandular tissue came almost up to the skin, and it was flanked by hypoechoic fat lobules here on the right and on the left. We saw down to the muscle, so we knew we were looking at the entire breast at that location. Well, could that explain it? How confident were we that the ultrasound showed no abnormality, in fact, explained the area as an area of glandular tissue? And we looked at the other side, and it didn't look like this. Area of glandular tissue that rose to the skin, was firmer than the fat lobules that flanked it. Well, here the automated scan really did help in increasing our confidence, and we were able to tell the patient that there was no abnormality in this area of breast tissue that she felt, and we were able to explain the reasons for her feeling it. Here in the coronal view, no change in the architecture. It was normal. The crosshairs are centered in the region of the palpable finding. I've taken them off in the other view so that you could see the area better as just glandular tissue, and asymmetric clump of it rising to the skin. When there are sufficient data and enough studies are done to support this as an indication for ultrasound and to rely on it to exclude any abnormality, I think we will be able to include this as an indication for automated ultrasound. In a multicenter study, we are looking at breast lesion detection at 6 sites, 3 in the US, 2 in Germany, and 1 in Japan. That will involve 250 patients per site for a total of 1,500 patients, to see if the automated scanner, the supine automated scanner, has detection capabilities that are equivalent to or better than those of handheld physician-performed examinations. We expect that they will be, and that ultimately the method for screening in the future will be with automation. In conclusion, automated scanners are important breast imaging modalities. Once supplemental ultrasound screening is improved, supported by the Akron 6666 trial data, we'll find increasing utilization of automated scanners. The automated multicenter trial, we hope, will establish that the Akron 6666 handheld results are achievable or better with automated scans, and that the automated scans will also, in addition to detection capabilities, will have diagnostic potential as well. And in the future, we expect that automated survey ultrasound will be the method used for screening because of its reproducibility in follow-up, its detection and capabilities and follow-up potential for benign masses, its rapid performance without involving a physician for performing it. It will allow handheld characterization and ultrasound-guided biopsy, and we feel that it can be integrated efficiently into the breast imaging workflow. Thank you.